Now, when we use the term T-cell dyscrasia, what does this mean? Well, I like to think about T-cell issues in the skin as existing on a spectrum. On the more benign end of the spectrum, you have dysregulation physiologically of those T cells that correlates with a mild degree of atypia and some minor changes in the immunohistochemical profile. Then you kind of move over a little bit to an early evolving mycosis fungoides type picture. And in that scenario, you would expect to see that things are a little bit more evolved. And then there are the well-defined cutaneous T-cell lymphomas of both indolent and aggressive subtypes. But today what I'm really talking about is that benign end trending toward that early mycosis fungoides picture. And so when you're counseling these patients on what's going on here, essentially what I like to tell them is you've got a dysregulation in your immune cells in your skin that is likely isolated to the skin, and it falls under a bunch of different names, which is what I was alluding to earlier. T-cell dyscrasia is one of these synonyms. Small plaque parapsoriasis, sort of an old-fashioned term, but certainly one that is used routinely to this day. Pseudo-lymphomatous drug eruption, cutaneous lymphoid hyperplasia. All of these terms, unfortunately, are confusingly used interchangeably, but they all kind of describe the same thing, which is some degree of T-cell dysregulation with inadequate clinical or histopathologic diagnostic criteria to label these patients as having mycosis fungoides. Now, what causes this T-cell dyscrasia? We don't totally know. We do know that it's linked with several categories of medications. These are loose observed associations. These are not, hard and fast, clear-cut cause and effect relationships. But I always ask patients about hydrochlorothiazide use and the chronology of the rash as it pertains to them being on that medication. Some patients can be on hydrochlorothiazide for a decade and then develop an issue. Take them off the hydrochlorothiazide, the rash goes away. So the only time that the chronology really can disprove that there may be a contributing element from the hydrochlorothiazide is if the rash predates the drug. Also, selective serotonin reuptake inhibitors as a class are linked with T-cell dyscrasias in the skin as well as mycosis fungoides. Anticonvulsants are also in this category. And then lastly, even more poorly defined are herbal supplements, dietary additives, things that are not regulated by the FDA, but that are used very commonly in the US. Those types of drugs can also contribute to some of these rashes that involve T-cell dysregulation and a small amount of T-cell dyscrasia. So when you encounter these patients, if you have the benefit of referring them to a CTCL multidisciplinary clinic, send them there. They're complicated, takes a lot of time to counsel these patients and educate them. They need to be followed over time, likely with serial biopsies, either every 6 months or annually, and we're happy to manage those patients. If you're in a setting where you don't have access to that type of clinic or tertiary center, then the guidelines suggest that you first, go through the drug list, try as best you can to remove any of these drugs that I've mentioned for at least a 6-month period to allow a washout. In cases where the patient is very anxious and wants to know, is this just a T-cell dyscrasia, a benign entity, or is this actually mycosis fungoides? There is additional molecular testing beyond T-cell gene rearrangement, PCR, that can be done. It's called high throughput sequencing, and there's a company called ClonoSeq that can assist with that. And with very high specificity, they can determine whether this is benign or malignant. And so I find this especially useful in the instance of a young, healthy patient who has tremendous anxiety and really wants to know in a binary fashion, do I have a problem or do I have a benign issue? And so about 6 times a year, I'll use high throughput sequencing in that type of environment. In terms of counseling them, it is important to counsel patients that mycosis fungoides can take on average 7+ years to fully declare itself diagnostically. And so you counsel those patients that they will be followed clinically and that serial biopsies may be appropriate to look for further maturity and further sort of diagnostic declaration histopathologically of an impending mycosis fungoides.